I'm delighted to have Jonathan Ramsey here today at the Agora. He comes down and does regular sessions here. He is a consultant urologist with a special interest in male fertility, and he is world renowned. We're really honoured to have him here. And personally, I've worked with Jonathan for over 20 years, and we've really developed our professional relationship in terms of analysing what we can do to improve the outcome when there's a male factor in the fertility problem. And we really want to have that analysis to get the best outcome. So I would like to ask Jonathan a little bit about what is the problem. If the sperm test is poor, should the man be worried, and what sort of problems could be underlying that?
Sure, thanks Carol. So, and I think I should probably say the reason I come down here is because Carol is one of the few gynecologists who actually gets it about the men. And I suspect I'm right in saying, Carol, that you've always had a sneaking suspicion that sperm could be to blame for some of the poor results that we get. And certainly in the last 20 years when we've been working together, we have paid great attention to the sperm, and my coming down here and seeing some men is merely an extension of what we used to do together at Chelsea. So this business of sperm count really does cause a lot of trouble. Of course, reasonably, when a sperm count isn't very good, then a man and his partner will be worried. The trouble, of course, is that it is only often the tip of the iceberg, because even when the sperm count is fairly reasonable, that does not necessarily mean that the sperm is of good quality. And the sperm count is very variable. There is biological variation, week to week, month to month, and depending very much upon what the man has been doing. Has he been exercising too much? Has he had a viral illness? There are many things that can temporarily upset a semen analysis. So one semen analysis really is not enough for a proper diagnosis. The other thing within the semen analysis, because we know there are three parameters: the numbers, the motility, and the morphology. The morphology gives a great deal of trouble. It can often be quite troublesome to tell the difference between normal, which is only after all 4%, and a bit abnormal that may be 3%. But the trouble is that we're so used to giving meaning to numbers that difference, which may be biologically irrelevant, between 4% normals and 3, is enough to send a man into a flat spin, because he's sure then that he's infertile, and he thinks, crikey, if these sperm look abnormal, then so too will my babies. So I think that semen analysis is, of course, the principal tool, like a screening test really, to see whether the chap is probably fertile or probably subfertile, but actually it doesn't go much further than that.
Yes, and certainly one of the things that we identify at the first screening test is whether there are any sperm there at all. And so that brings me on to one of the main things that you do here in a surgical sense is sperm retrieval. Could you tell us a little bit about that?
So we're talking about an obstructive azoospermia when there are no sperm in the ejaculate, but when all the other signs are that the man is making sperm, because he's got normal volume testicles, because he has normal hormones, he has normal genetic tests, and then when we examine him, we can often feel that the epididymes, which are the little storage tubes on the top and the back of the testicle, are rather distended. And in that case, this is an obstructive azoospermia, a bit like when a man has had a vasectomy. And then it is a relatively simple matter to aspirate sperm, to remove sperm by putting a needle through the scrotal skin with lots of local anaesthetic and sedation, and then to be able to aspirate motile sperm, which your scientists will freeze, and then when thawed can be used for ICSI. So with obstructive azoospermia, under the right conditions, this is a a relatively easy procedure, never mind for us, but I think particularly for the man himself. It sounds ghastly when you explain it, but actually the reality is not too bad.
No, it's something that we've done quite a lot of cases and had some wonderful success rates after when we do the ICSI using the sperm that's been retrieved and frozen. And are there any hormone options that you use in men? Well,
certainly not for obstructive azoospermia, because of course the men with obstructive azoospermia are producing sperm, it just can't get out. In oligospermia, where there may be very low numbers of sperm, and indeed so low that one struggles to find them, and in certain circumstances when the hormone levels can be adjusted, then there are medical options to try to convert that very low, that very severe oligospermia, so few sperm in the ejaculate you can hardly count them, to convert that into having sufficient numbers of sperm to freeze a sample as a backup, and then with any good fortune to use that sample for a treatment cycle.
Yeah, no, that's something that again we've had some really good success rates with. Now, over the last 2 years, you've convinced me of the importance of DNA fragmentation testing, and we've developed the enhanced male fertility test at the Agora, which I've already spoken about in an earlier episode. So I really want your thoughts on DNA fragmentation testing and some of the things that we should be doing to further explore what might be the root cause of elevated DNA damage.
So of course, DNA damage, it comes as no surprise. DNA damage, some people much cleverer than I would say, is the root of most disease processes. It's certainly something that happens with aging. So it is not really surprising that poor quality sperm in men who have had difficulty in creating a pregnancy may have DNA damage. And the way I describe it to patients is that we have a certain number of sperm vehicles. Those are the sperm with their heads and their tails. And we can imagine those rather like transit trucks, little Ford Transits. But what really matters, once the truck has got to the port, is its cargo. And the cargo is the DNA. And so one could have a whole fleet of Ford Transits that move quite quickly up the motorway. But if when they get to the port, their cargo is not of good quality, then of course we have a problem that was up until that moment unseen. So the DNA quality of sperm is about the DNA that is compacted in a very tight ball within the sperm head. And there are many things, inflammatory processes, principle, what we call oxidative stress, which again may be an expression of inflammation, which might attack the sperm head and cause the DNA within the sperm to become more loosely packed or fragmented. And when this happens, then it may create a less robust embryo, which may only implant briefly or may miscarry early. And indeed, such sperm may not give us as many 5-day blastocysts. Those are embryos that have developed for 5 days in your laboratory, as we might expect. So DNA damage, which may be unseen in terms of the semen analysis, may be highly relevant to the outcome not only of natural conception, but also of assisted conception.
And this is what I feel. And so, this episode is not just directed at heterosexual couples who've been struggling to conceive, but also at men who are in a same-sex relationship, who want to go down the road of surrogacy. It's become to me quite important to inform them that we need to perhaps look at the sperm in a little bit more detail, so that they don't find themselves a year or 2 years down the line with an embryo that's not as good as it could have been. And of course I called this episode Sperm, Sex, Sport and Supplements for one very good reason, is that is part of the chat we have if we find DNA fragmentation levels to be high or abnormality rates to be high. So tell me a little bit about your thoughts, particularly around, ejaculatory frequency, supplements.
Sure. Absolutely. Well, indeed. So, of course, it's all biology, really. And we, in our profession, with our scientific friends in the laboratory, the World Health Organization, who actually determined normality of men's semen parameters, we have really conspired to produce something that is just not biological. Because our conspiracy says that when a man does a semen analysis, there should be at least 3 days abstinence. And therefore, when he presents his sperm to a laboratory for IVF or ICSI, 3 to 5 days abstinence. And therefore, when men and their partners are thinking about sex at home or even the treatment cycle, they sort of understand that it would be better to perhaps delay or extend ejaculatory frequency to sort of save it up for the big day. But of course this flies in the face of biology. Quite simply put, animals can't count. And most men teeming with sperm were designed to populate a small village, because of course procreation is largely an opportunistic act. And therefore it follows that better quality sperm may be derived from more frequent ejaculation. Certainly every other day, maybe even every day. And therefore the DNA quality of the sperm, which is a much better way of measuring it than is a semen analysis, may actually be better with frequent ejaculation, even sometimes on the second ejaculation on the day of presenting sperm. You remember that the crafty old IUI practitioners often use the second ejaculate?
Yes.
So before there was IVF and ICSI, all there was IUI, putting the sperm into the uterus, and this was all craft. And I remember some of them saying, do you know, the second ejaculation, those ladies do better. And so now we have a way of measuring that, which is again the DNA fragmentation.
And cycling. I mean, the lockdown has brought out the bikes. We've got all sorts of cycle lanes here down in Brighton. So I often get asked, should I be cycling? And what are your thoughts on cycling frequency?
Well, it goes back to the biology again. So there's the farmer's bull in the field, and it's obvious to all of us that he is wearing his testicles almost outside his body. And indeed, if you measure the scrotal temperature, the ambient temperature, in unclothed men in temperate circumstances, then the testicular temperature is 3.5 degrees below core temperature. Now that's actually quite a lot. 3.5 degrees below core is a fairly tepid bath. We'd feel slightly uncomfortable in that. So spermatogenesis, sperm production, enjoys this much lower temperature. And of course everything we do in modern life, but particularly with regard to cycling, tends to pull the testicles into the body, to coat them in insulating tape, otherwise known as lycra, and then the saddle presses on the prostate, and then the cyclist is often competitive, so his core temperature goes up with the testicles pulled into the body. So the consequence of that is a reduction in spermatogenesis.
And that brings me on to the varicocele, which is we've gone through 20 years of deciding whether we should or shouldn't be worried about the varicocele.
Well, we should. There's really only, as you and I have discussed many times, there's really only one thing you need to know, which is factual, which is numeric, which isn't open to complicated meta-analyses. There's only one statistic one needs to know to apportion relevance to varicocele. So that if you look at the incidence of varicocele in a young male population, which was done in a military hospital, the Walter Reed Hospital, the one where President Trump was taken. So one of the army doctors there, his life's work was examining young army recruits. And he examined 5,000 of them and defined the incidence of varicocele as around about 12% of a young male population, in a very large number of men. So if that is the incidence in the population at large, the next question is, what is the incidence of varicocele in sub-fertile men? To which the answer is 40%. So therefore, it has to be relevant. What upset the apple cart in the last 20 years were meta-analyses. Meta-analyses, so putting lots of studies together to apparently produce the statistical power that comes from 57 patients in one study, 120 in this study, 200. So that when you add 30 studies together, you apparently have 2,000 patients and therefore huge statistical power. The problem is that if you have not done a very careful review of all of those papers that you've put together to define the homogeneity, to make sure that they are similar, that they have the similar standards and they're looking at the same outputs. If you don't do that properly, then your meta-analysis is nonsense. And that's what happened around about the year 2000, which is why we've spent 30 years doubting varicocele. But while nice, and in the UK we have made pretty clear statements that you shouldn't bother to treat varicocele, which of course is quite wrong, as you are saying. Meantime, both in Europe and in North America, the guidelines are saying quite clearly that for significant sized varicoceles, where you can measure the veins, and particularly when the DNA fragmentation is raised, then varicocele treatment is most certainly indicated. And I think that's where we are certainly here, and I think where most urologists are coming to.
So thank you very much, Jonathan. Really, really helpful. Really enjoyed that discussion.
Lovely, Carol. Nice to be here again.